Eastern Time. Thank you all so much for joining us. I'm Jessica Solomon Fisher, Vice President for Program Operations at the Public Health Accreditation Board, and very excited to be your moderator for today's event. We are here to talk about staffing up, strengthening the public health workforce for the next generation, and have a really exciting hour planned that's been a long time in the making. On the next slide, you can just see what our project goals were when we started this. I'm sure I'm preaching to the choir when I say, obviously for years, a disinvestment in public health departments has led to a crumbling public health infrastructure, lack of modern data systems, and an inability for health departments to equitably provide necessary services to communities. And certainly much has been written about what health departments should do, but there's been little available to guide health departments or appropriators when determining what staff are necessary to deliver those services. We also know we've had a 15% decrease in staffing in health departments due to a lack of consistent investment in governmental public health. Compounding that, of course, the current continuing exodus of staff at all levels since the start of the COVID-19 pandemic years ago. So a number of partners that are listed on the next slide came together, and first, a smaller group of partners started working on the development of an estimate to really understand the need for implementing core public health, and then to develop a tool that could help health departments use data to plan what staff they need. So we now have the data. We need to build support and fund health departments to perform their roles in protecting health, as well as a tool to help health departments with that planning. On the next slide, you'll see just images of our great speakers today. I am going to turn it over to JP Leiter, who's going to give you a little bit of insight into the methodology used and what exactly we did to derive these estimates in this tool. We'll hear from Sarah Ravenhall, basically a use case or a story about how she and her colleagues were able to use the estimate. We'll then turn to Mariah to really get a demo of the calculator, and then hear some closing remarks from Liza Corso. So JP will provide kind of that big picture of the what's, and then we'll dissect it going one at a time with Sarah and Mariah in terms of what the estimate is and how it was used and how the calculator can be used. And of course, we will save time for questions from you all at the end. You can feel free to chat those into the chat box at any time, and we'll be poised to have a discussion at the end. So with that, I will turn it over to JP.
Thank you, Jessica. I'm JP Leiter. I direct the Center for Public Health Systems at the University of Minnesota School of Public Health. And in the next few minutes, we're going to talk about the development of staffing up, the estimate that led us to find that we needed 80,000 more staff prior to COVID to deliver the core or basic foundational public health services. From that to be able to develop the tool that we're talking about today, the staffing up calculator. In the next few minutes, we'll go over those basic numbers and talk about the methods that got us from here to there. The other part of the core goals that were to generate totals and ratios. So how many FTEs and staff do you need per 100,000? And the recommended infrastructure from which you can build to surge during a crisis. Next slide, please. This calculator is the second phase of the estimate. So later in this presentation, you'll hear from Mariah how to work through a few different modules in the calculator, both for basic users and advanced users. This calculator was kind of the ultimate aim of the staffing up project, the second phase, if you will. And it was a tool that was developed to be able to provide health departments their own practical use case to do resource planning and management so that they could look at the foundational public health services and how their current staffing related to what the recommended levels were from the staffing up project. Next slide, please. Let's spend just a few minutes in the methods. While I would be happy to talk for hours, I think we'll spend maybe just 2 or 3 minutes, though happy to answer questions about it. Staffing up benefits from the rich data sources we have in our field from the ASTO and NACHO profiles. the Public Health Workforce and Interest and Needs Survey, and then importantly, financial and FTE and staffing information from about 170 local health departments in 4 21st century public health states. These are states that rigorously went through different kinds of exercises. So each of these 4 states tried to answer a similar question, but did so differently. They answered, what do we have now in terms of the foundational public health services, staffing and spending? What are we doing in terms of public health? And then what do we need to fully implement the FPHS, to fully deliver foundational public health services? From these about 170 local health departments, we were able to determine what was needed at the kind of local health department level, and then eventually at the state health agency level. So construct a national estimate and then derive for this calculator individual agency level planning estimates that you all will be able to use, and we'll talk about more in just a moment. Next slide, please. One thing that we wanted to be able to consider is, at the end of the day, what is the most useful approach when considering and creating a national model? So over the course of a year, we entertained and modeled many, many different approaches with these and other data. So on the last slide, we showed you kind of ultimately which data were used, but we considered many, many different data sets, data sources, and permutations and mixes of those. So we considered rurality, service mix, different measures of health and social need. But what was very interesting to us was that the best performing model by far was a fairly straightforward mix. A fairly straightforward model that was a power curve of a log of FTEs by population size. And so for those of you who do this type of work, we were looking at the FTEs of the current staffing, FTEs of the current FY 2018 core service provision of staff, and then looked at what they would need by health department to do full implementation. So importantly, this was pre-COVID-19, and is probably the most important limitation of this calculator. So as you're using it, and as we talk about the calculator use, please keep in mind this is pre-COVID-19 data, but is important as you consider the use case and surge potential. Next slide. When we built out the first phase of the analysis, so staffing up 1.0, we found that state and local public health agencies needed approximately an 80% increase in the workforce to provide a minimum public health services, to provide the foundational public health services across the US. And this meant approximately 54,000 more FTEs across locals and 26,000 more across state health agency central offices. But importantly, this is just for foundational services. This does not include all the critically important community-specific services that local health departments and state health agencies also provide. So this, again, is the minimum that we feel must be provided at local and state health departments across the country. Next slide, please. Some of you may have seen this earlier report released back in February now, I believe. And I just want to spend a moment on it before moving on to the calculator. What you can see is that across the different foundational areas and capabilities, these FTEs are not distributed evenly at all. There are certain areas of capabilities that need far more staff than others, both at the local and state level. So on the next slide, you'll see that if you'd like to learn more, there are 2 primary ways you can do that. One is that there is a full detailed report. There are actually 2. One is a short report and one's a full methodological report that you can see on the PHNCI Staffing Up website. And then I think just last week, the peer review paper at JPHMP was released ahead of print, and you can see that here. So happy to answer questions about this. This is phase 1. So this is the work that we completed earlier in the year, and I'd like to turn to phase 2. Next slide. Because that's what we're here today to talk about, which is the Public Health Workforce Calculator. In phase 1, we were creating national estimates. This is where we were trying to understand what is the depth and breadth of need nationally across state health agencies, central offices, across local health departments. That's where we found, after kind of extensive modeling and review of available data, that we needed at least 80,000 more FTEs. But in phase 2, in this calculator creation, we were trying to create this tool, again, to help individual health departments have some kind of planning estimator that they could use when trying to do work in their own community. And that's what we're going to go through today. Next slide. So what should you know as you consider using this tool? The first is that this tool is for planning purposes only. And please consider that as you work through it. As with any dashboard, as with any tool, this is taking kind of ecological data and it lacks your local specific context, right? So you always have to take into account your local context as you're getting numbers out of this this tool that's using basically national and averaged information. This is using the data that was used to create and construct the national model, but it is kind of extrapolating to agencies that are based on kind of the size that you're putting in, rather than your specific agency. And that distinction, I think, is kind of important. Similarly, the calculator only is providing estimates about foundational need, but not community-specific need. So it's not necessarily the total workforce gap you might have in your community or in a community of a similar size, I should say, but it's just foundational. It's not foundational and community-specific. And that gap could be very substantial if there are substantial community-specific needs within a community like yours. These are very, very different estimates. We're looking at foundational needs because these are the needs that public health needs to satisfy everywhere for the system to work. There are certainly community-specific needs that need to be met in one's own community. And then based on data limitations, this calculator is essentially built for agencies from decentralized states, so states where local health departments are independent from the state health agency, and for those serving under 500,000 people. This is because for the local health department data from which the calculator is built, that's where the most reliable data come from. That's where we have the most health departments contributing to the model. So if your agency looks different than what I just mentioned, you can still literally use the calculator, but please keep in mind your estimates may not be reliable to your local context. And if you want to learn more about that, that's available in the manual. We can answer any questions you might have about that on this webinar. All right, next slide. So what are a couple use cases? So there are a few here, but there might be many more, and we can talk about them in the Q&A today. So we have two modes for the calculator, a basic mode and an advanced mode. So in the basic mode, you really only need to put in the kind of the size of the population being served. And in the advanced mode, a lot more information, but you get quite a bit more control and information out. So in the basic mode, maybe senior leadership wants to put information into the calculator and just get a quick piece of information out about, say, foundational staffing and the areas and capabilities when considering a budget ask to the county council, so they can compare, say, where their actual staffing is relative to maybe perhaps expected staffing of similar or benchmarked peers, right? That might be a particular use case of interest. Another could be that there's an MCH director that wants to use the advanced expanded version of the calculator to look at FTE totals to benchmark comparing foundational versus community specific staffing priorities when they're trying to balance staffing within their unit. A final and probably the most common application that we think is that senior leadership might want to use the advanced expanded mode. So this would be the most expanded or intensive use case of the calculator when participating in what are called cost and capacity assessments, part of the PHAB and PHNCI 21C learning community, or as part of the forthcoming CDC workforce grant cycle work. So this is if you have workforce needs assessments that you're doing, you're trying to understand what do I have in terms of staffing and spending, where do I want to go in the future, how does that compare to my peers? This is sort of essentially exactly what the advanced expanded version of the calculator is built to assist with, and the manual we think can help quite a bit with. Next slide, please. But some final considerations for you as you consider using the calculator, what version of the calculator or module in the calculator is right for you. While it is the case that the basic version would require fairly little user input or pre-work, please keep in mind that the advanced version, which Mariah will demonstrate in just a moment, it allows a lot more user control, as you'll see, but it also involves a lot more pre-work. So the basic version, as I said, really only requires that you will use population information, but the advanced one will ask for a lot more information from you, give you a lot more back, but you'll probably have to do quite a bit more pre-work before you use it. Also, it might be prudent to consider checking in with your peers in the 21C learning community, or potentially other kind of workforce consultants and the like, as you want to use things like the workforce calculator or any other kind of job tool in this area. While we hope that the manual will answer many of your questions, very likely your peers or other support members might be able to help. The last thing that I'll say is, while we think that the calculator provides useful and helpful information, please be circumspect and critical of the output. If the numbers seem a little strange, probably they are strange. If they don't seem practical, if they don't seem plausible, probably they are impractical and implausible, especially if you're using the advanced interface, because that allows you to kind of tinker with the settings based on, say, need in your community and the like. One very kind of practical piece of advice is you can always reset the parameters. As you'll see if you try it out, if you're getting very strange outputs, why don't you just reset them to the default, see what you get, see if it still seems strange, and go from there. So with that, next slide. I'll leave you with happy calculating and turn it over. Sarah.
Thank you so much, JP. Congratulations to PHNCI, to Beaumont, PHAB, University of Minnesota, and all those who were involved in the development and launch of the Public Health Workforce Calculator. I'm Sarah Ravenhall. I'm the Executive Director at the New York State Association of County Health Officials, and it's an honor to present to you today. And today, I plan to tell you a bit about how our members, the local health departments in New York State, creatively used the staffing up methodology to share stories about the importance of increased funding to local public health departments in New York State. Next slide. In New York State, our local health departments are decentralized, and there's one local health department per county, plus New York City Department of Health and Mental Hygiene that covers the 5 boroughs. 21 of our local health departments in New York are partial service, meaning they don't deliver environmental health activities. They leave those responsibilities to the state employee district office employees. And many of those partial service local health departments in New York are rurally situated, and they have smaller staffing sizes. Next slide. These are the 6 core public health services in New York State, and they are written into state public health law, and therefore they are responsibilities that the counties are legally obligated to provide in law to their communities. So when thinking about staffing up and modeling, and how they use their connection to the foundational capabilities, it's important to recognize that what we did in New York may not be directly comparable because there are differences between those 2 frameworks, the New York State Core Public Health Services on the screen here and the foundational capabilities. Next slide. Also important to note, when looking at population sizes in New York State, New York is largely rural. 26 of our counties serve populations that are under 75,000 in size. Next slide. This is an impactful image that represents the $193 per person that is spent on public health services versus the $3,869 spent on Medicaid or clinical services in New York State. And as we know, there seems to be a huge discrepancy between spending on prevention or public health versus clinical services, not only in New York State, but in other states as well, and of course on the federal level. And to clarify, funding clinical services is extremely important, but focusing on funding prevention services, what local health departments do, is equally as important, and especially if we want to address those social determinants of health. Obtaining these numbers so that you can make a comparable graph is definitely something you can do if you tap a partner who has a skill set to evaluate and assess your state budget documents, to identify funding lines that go to public health versus Medicaid, and then dividing those numbers per capita in your state. Next slide. Here is another spending slide that shows cuts over time to public health agencies, which may be very relatable to all of you, but we all have a collective goal to reframe and refocus how public health is funded at all levels, federal, state, and locally in our nation and worldwide. Next slide. So I imagine many of you are in a very different position than I am as the executive director of an association that holds some lobbying capabilities. You know, that's great, but we also at our association engage our members to educate policymakers and give local examples to how policies that are set by the state influence their work, which is what I imagine that most of you listening in today have the capability to do. Educate and share stories. My ability to lobby or ask for direct money does nothing without bringing in folks that can share stories. Everyone here has the power to tell stories and use your voice to educate key decision makers. And I would certainly recommend you consult with legal counsel to make sure you're aware of any restrictions you might have working with policymakers. But once you have the message in hand and know how to use it, you can accomplish a great deal. Next slide. So last year, October 2021, leading up to the New York State budget negotiation timeframe, we knew the time was right. The state was flush with funding. Our members were continuing to work intensely on pandemic response. The political appetite was actually in our favor, and staffing up, the report brief landed in our inbox. Our first thought was, how great will it be to be able to point to this national publication? But then we realized we need to be able to dig in and make that messaging more real for our audience by applying the numbers to New York State. So to get started, our first step was to obtain numbers of full-time employees by county, which we obtained from our friends at the State Department of Health, but you could also collect that data from your local public health agencies. We decided to include anyone working to deliver New York State's core public health services, since staffing up was compared with the foundational capabilities. Step 2 was to have conversations with the researchers who knew how they calculated the staffing up data on the back end, and they were very generous in helping us to apply data curves to New York State data. However, with the launch of the calculator that we're celebrating today, you no longer have to worry about that. The calculator will do the work for you. And then our third step, because we're working from a state level perspective, we didn't want to spotlight any local health departments or counties that had, you know, not enough staffing, or with the staffing up model, or maybe they didn't have enough. We didn't want to spotlight anybody. So we de-identified the data and we rolled it up into a statewide level data perspective. And then finally, it's important to consider data limitations. There are always going to be data limitations as long as you're transparent about them. So our first limitation, you already know, was the distinction between the core public health services and foundational capabilities. And then the second, the differences in New York State between full service and partial service local health departments. Next slide. When applying staffing up to New York State's public health landscape, we determined, limitations aside, that 90% of New York's local health departments do not have enough staff to provide a core set of basic public health services. And that secondly, over 1,000 additional full-time staff are needed to provide an adequate public health infrastructure in New York State. This graph shows the number of full-time employees that are needed by population served in New York State. Next slide. These two facts derived from staffing up really shaped the layout of our proposal to fund local health departments, but we knew we needed to get creative and package this in an exciting, appealing way. So we coined this proposal the Public Health Reinvestment in Emergency Pandemic Adaptability, Readiness, and Efficiency, or the PREPARE Act. I know it's a mouthful. Components in this act included resource requests that are priorities for our members and requests that we know would help to enhance public health infrastructure in New York State. And we also developed things like press releases, sign-on letters with partners. We put together social media campaigns to help spread the word about it. If you're interested in seeing it, you can visit our website, www.niceho.org. I think it's still right up there on the webpage. Next slide. And our advocacy here resulted in a $51.4 million increase in the state budget to fund core public health services. This was a huge accomplishment that we couldn't have done alone. And now we're working locally to find ways to maximize and spend this funding increase. And I just want to point out, while NYSHO is a statewide association and our focus was to influence the state level budget, this information could be shared at all levels of government to gain support for public health. Your local elected officials may be interested to know how their staffing compares to the calculator estimates. And in closing, I do have a few recommendations for those who are looking to get started. Take advantage and visit that PHNCI workforce calculator to see where you stand. A few months ago, the CDC released a funding announcement, and states have already sent in their applications for the Strengthening U.S. Public Health Infrastructure, Workforce, and Data Systems Grant, funding components of which support both the state and local public health infrastructure. And I should note, while I represent localities, we still want to see increased funding to our partners at the state so that we're collectively strong across the board. Hopefully, and I'd be interested to see if anybody is able to use the calculator estimates to help them better utilize data from the CDC grant. Secondly, pull in partners, find data savvy, research-oriented people who have a heart for local health departments and the work they do. Using the PHNCI calculator could just be a starting point for you. For us, it was the first step we needed to embark on a full workforce enumeration research study in New York State. And I just want to shout out to our partners who have been helping with that. Sylvia Pirani, Isaac Michaels, Mayela Arana, Christian Gloria, Heather Kosna, and others at Region 2 Public Health Training Center, but especially Molly Fleming at NYSHO, who took the lead on the project. Third, practice your messaging. If you're not the person to carry the message, find willing partners to carry your message forward about the workforce needs in the public health sector. And as we know, public health is resilient and we never give up. New York State has been working to obtain an increase in public health funding for nearly a decade. So this wasn't an easy go. I hope some of these ideas are helpful to you, because with public health funded more equitably on a national level and state and local level, we'll all be in a better place. Thank you for all that you do. Please don't hesitate to contact me if you have questions. And at this point, I will hand things over to Mariah.
Okay, Hi, everybody. My name is Mariah Robbins. I'm a Senior Research Associate at the Beaumont Foundation, and today I'm going to walk you through how to use the calculator. So let me share my screen so you all can see that. All right. Okay. So first things first, you've heard a lot of great information about the calculator. Some of the stuff that I will be telling you will be repetition from things you've heard earlier. But to get started, we should just talk about how you get to the calculator. So Naomi will drop the link to the calculator in the chat. But if you don't have that link handy, you can just go to phnci.org. And at this, at the bar at the top of the page, there's that transformation. And in the drop-down menu, you'll see workforce calculator. And if you just click that, it will take you to the page with the workforce calculator. So on this page, there are a few things you should note. First, there's an introduction here, and this introduction reminds users that the calculator is really meant for decentralized local health departments that serve a population of 500,000 or less. There's also a user guide available for you here, which I highly recommend you download and have next to you the first few times you use the calculator. It's really handy and has a bunch of screenshots and tips for you to use as you work your way through the calculator. There's also an FAQs document, which is not available yet, but will be available shortly. The questions that are asked today will be used to update that FAQ document, so we make sure that we're giving everybody the correct information when they come to the website. And then the calculator appears here, but quickly below the calculator, you'll see some notes on the value of the calculator, including that research brief that was shared earlier today in the chat. As well as a little note about the methodology for the calculator and some additional resources and acknowledgements as well. So now that we've gone through the whole page, let's launch into the calculator itself. So as JP talked about earlier in the presentation, the first step to using the calculator is to decide what type of user you'd like to be. So there's a basic user and an advanced user. A basic user is a local health department that has not participated in a foundational public health services related capacity and cost assessment. So this form of the tool is a little bit easier to use. It asks you to rate yourself relative to your peers, which I'll get into a little bit more in a bit. And the advanced user is someone who's participated in one of those FPHS related capacity and cost assessments, and they have the data on the number of FTEs that contribute to each of the foundational capabilities and areas. So quickly, I'll just click into the advanced calculator so you can see what that looks like. When I say that you need the data to put in here, this is what I mean. You'll have to input all this data on your current staffing numbers, foundational numbers, and what percentage is provided by your local health department. And then you can use this home button at the top to go back to the screen we were previously on. And quickly, I also want to point out that there are two versions of each user version. There's a streamlined version and an expanded version. And the main difference between these two is that the streamlined version aggregates 6 of the foundational capabilities into an all other category. And the expanded version allows you to provide separate inputs for those 6 foundational capabilities that are collapsed in the streamlined version. So today, just to keep it simple, so we can talk about it, I'm going to be using the basic streamlined version of the calculator. So we're just going to click into it. And as I mentioned before, there's a home button right here at the top that will take you back to that home screen page. There is this button down here, which is the enter button. So once you've put in all your information, this will take you to the output page. And there's also this download image button, which will allow you to download this image if you'd like to drop this into a PowerPoint or save what you've put into the calculator so you can come back to it at a later time. So the first step into entering the right data is selecting your state. I am currently based in Maryland, so I will be selecting Maryland. And this box just allows you to type the name of your local health department. They won't pull a list or anything like that, but this will allow your health department's name to appear on the output page. So if you are to download that page as well, the correct health department name is at the top. So today I am just going to type in calculator demonstration. Okay, and then the most important piece of data when you're using the basic version of the calculator is how many residents your jurisdiction serves. So today I'm going to say that my jurisdiction serves 150,000 residents. Okay, excellent. So that is the initial information that you'll need to put in. And now we get to the FPHS information. So as I said, both versions of the calculator ask you to rate your relative need based on your peers. And a peer here is defined as a local health department that is similar to you in terms of the capabilities that your health department has, and also the population size that you serve. So that can be geographical area, or it can be a health department that has the same breakdown in terms of capabilities as well. So from here, we're just going to go through the FPHS and rate our relative need towards our peers. For this demonstration, I will just be choosing a need of much less, less, average, more, or much more, but you will all be giving it a little bit more thought than I will be doing right here now. So I am just going to click some things so we can get an answer. And also I mentioned before that there's the expanded version and the streamlined version. So I'm currently in the streamlined version, which you see here is all other, and it makes a note that the 6 capabilities on the expanded version, these are the 6 capabilities that are broken out in those versions of the calculator. So let's just click through this a little bit. All right, excellent. And then at the bottom, you're able to provide a scenario. Again, this scenario will just show up on the output. So if you are to download it and want to relate it to something specific, you can do so. So just as a test to show you how it works, I will say workforce calculator demonstration. And then we push the input button. And that will load. I imagine a bunch of us are all on this calculator at the same time, so it's a little bit slow right now. So if you'll notice, there's this little back arrow right at the top if you'd like to go back to that input screen and change anything. But overall, this is the output. So you can see that it has the state that I put in. It has the scenario that I typed in as well. And it says for my population, which was serving my health department, which was serving a population of 150,000, I need about 62 FTEs, 61.6 to provide the FPHS for my jurisdiction. And so if you look, it says that you should have nearly 3 FTEs expected for assessment and surveillance, 3.9 for emergency preparedness. And if you remember, I'm pretty sure I selected much less or less for these. So these might be less than the average amount that you'd see. Just remember that it's relative to your peers. So as JP mentioned, if things look wonky, they might be a little wonky, and you should evaluate that appropriately. And then lastly, I just want to show you, I mean, the printout is pretty easy to read. The foundational capabilities in total need about 22.6 FTEs, and the foundational area is 39. And then you can download this image. And I will just show you quickly what the download looks like. You hit download. And that is what it will look like. Oh, you all probably can't see that because of how I shared my screen. But regardless, you can download it and it looks just like this. You can drop it in PowerPoint or share it with appropriate people should you want. Okay. That is pretty much it for the calculator. It's fairly simple to use. Again, you can navigate back to the home screen where you chose the different versions by using this home button, or back to the inputs by just hitting that back arrow. And with that, I will pass it over to Liza, who has a few words for you all.
Thank you, Mariah. And thank you to all of our other speakers today as well. I think you can see from what you heard from the Beaumont Foundation and PHNCI and from JP that they represent only a small part of the brain trust engaged to develop this tool. We had some amazing expertise that was leveraged to develop this. I also want to give a shout out to Sarah. The impressive work that New York State has done is actually only one example in terms of also the impressive work and effort that so many health departments did in providing data. And that's what, of course, allowed us to be able to develop this calculator. So please continue to, we've been seeing all sorts of questions coming into the chat. Please continue to share your questions. We're going to segue to Q&A in a moment. But I first wanted to just quickly acknowledge the amazing partnership that allowed us to develop this calculator, and note that, of course, now is a time when there's unprecedented and significant attention to and investment in public health workforce. So we really do think this is a matter of the right tool at the right time, despite the limitations in how it can be used. So with that said, I'm going to pass it over to Jessica. If you can, we can begin to coordinate answering and addressing some of these questions.
Thank you. And thank you all so much. A lot of really great information shared, and we know it was very fast. I appreciate all the questions that are coming in. We are going to do our best to address as many of them as we can. And as was shared earlier, the FAQ document, will be updated to include all of the questions, because I suspect we might not get to them all, given how many there are and how many people are on the line today. So first, I just want to note that a lot of you have been sharing great links in the chat box, not only our links that relate to this effort, but some of you, just sharing peer-to-peer. So thank you for that. The slides, the links, everything will be shared with the archive after the event. A couple of questions have come in about users, in particular about whether territories were or would be included. I imagine the same question might be for tribes. And then speaking a little bit about the centralized states and this being for decentralized states. I don't know if JP, you want to take that one?
Yeah, I can hop in. So I would say that the first question, the tribal data and territorial data were not included in the calculator because we didn't have good comparable data for current and full implementation, as we did for the 170 local health departments from the 4 states that I had mentioned earlier in the presentation, to be able to build out the kind of staffing up model that I had mentioned before. So I would say that my expectation would be that this might be of modest to less utility for those groups in particular, especially given the kind of heavy clinical mix of services. So for the population-based services for those settings, perhaps useful as a comparator, but especially as you start to get into the more clinical side, I would suspect less useful. For those asking about the centralized states, I would say this is a substantial consideration and limitation of the calculator. This calculator has data from decentralized localities and doesn't have comparable data yet from centralized localities. So I would say the data are less reliable, and this is really important because there's a pretty different service mix and delivery of services between state health agencies and locals based on governance. So I would really be very cautious if you are in a centralized jurisdiction using the calculator, unless you're planning kind of a different delivery system. So I would say this is more intended for decentralized jurisdictions, and please view it not with a grain of salt, but with like a bag of salt if you're in a centralized jurisdiction.
Thanks, JP. There were also a number of questions that I think are really getting at definitions. So I'll say a word about that and then ask others to chime in. So in thinking about the foundational capabilities and the foundational areas, these are defined through the national framework of the Foundational Public Health Services, which is housed by the Public Health National Center for Innovations, which is at PHAB. The link was put in the chat box. So those are what is defining what's kind of behind this. The states that contributed their data may have slightly different versions. And JP, maybe you can speak to how that worked from a methodological standpoint. But in general, we're using the definitions of the national model for the Foundational Public Health Services, which are available now and for which we are developing another level down. So even kind of a more granular level of definitions, and those will be available in coming months. JP, is there anything you want to say about the definitions, or does that cover it? Okay, fantastic. There have been a number of questions also about explaining peers and why you would relate your agency to a peer agency, in particular if all health departments are understaffed. So if we could say a little bit more about how we're determining whether you're average, above average, et cetera, for the basic version would be great.
I apologize. I think my Zoom just cut out for the last sentence if it was directed toward me.
Probably, unless anyone else wants to speak to it. I think you're the best one. I know we've talked a lot about it during the project. You'll give the best answer, I think.
No, I apologize. I think I had a technical glitch. I literally didn't hear the question if you directed it toward me.
Oh, I got it. So the question is about need relative to peers and why that's relevant in this model. In particular, the question was posed around the fact that if all health departments need more staff, why would I relate myself to peers?
Got it. Okay, that time I got it. I apologize all. We tried in creating this calculator to balance the idea of wanting to have a reliable model where you got solid estimates out that that folks would get kind of no matter the context, right? That you would get reliably out, but that would also be kind of sensitive to local need, right? Understanding that there would be local contexts that would mean, my jurisdiction is different than yours, even though what we're talking about is still foundational, right? Still foundational services, that there's still something different between where I am in Hennepin versus folks say out east where you are, Jessica. And so our solution to that was to allow for these user inputs where you could indicate that there was a little bit of difference in terms of how services were delivered, but also this idea of need relative to peers, where even for the foundational services that were being delivered, that the depth of your need for addressing those foundational services were a little bit harder or a little bit less challenging to meet. And that modulation, the user interface could handle when accounting for staffing needs. So just so folks know, and we kind of transparently talk about this in the manual, that's kind of a straight mathematical calculation on top of what the model outputs. So it'll multiply kind of a percentage on top of the FTE output up or down based on what you say. So just so you know, that when I and Mariah said before, if you're getting kind of weird numbers, it's very likely coming from that right there, or from the other user input where you're talking about the percentage of FTE being, or percentage of work being done within the agency.
Thanks. I'm going to turn to outputs, but first a very specific question for Sarah that came in, which I think was really getting at, how did you allocate the $54 million, in particular in thinking about that different health departments have different needs?
Yeah, I mean, in New York State, we have something that's called Article 6 State Aid. It's a reimbursement program. So all local health departments perform their core public health services and then submit for reimbursement. And so the state allocated it based on the county size. It's a complex formula, but the county size. And then they get a base grant. And then after that base grant is spent, then they get 36 cents on the dollar. So it was already set in state statute how it was going to be allocated. But I think the more important component here is now we need to kind of get over some local barriers we have to spending and make sure that, like, at the local level, everybody understands why it's important in investing up front and putting local money toward public health or filling public health vacancies to take advantage of this increase in state funding. And that's definitely going to be a challenge, but it's something we're going to have to kind of plug away at.
Thank you. So in thinking about the outputs specific to the calculator, this question is for anyone who wants to chime in. Do you have suggestions about how to estimate community-specific needs? For example, might you look at the community health improvement plan? So in thinking about the foundational public health services model, there's the foundational capabilities and the foundational areas, and that's accounted for in the calculator. But as you heard, what's not accounted for is those community-specific needs. So how do we determine staffing needs for that? Does anyone have any thoughts to share?
Sure, I'll hop in, but I would invite everyone to talk about this. Community-specific needs within public health are super broad and super deep. And I think that when you look at the calculator, there are probably areas that have the same names, right? The same names, the foundational areas and capabilities that are community specific. And you can think about, well, does it mean I just need more in chronic disease control and trying to think about, do I just need to try and address that more deeply with more staff, or do I need to have new kinds of interventions, or do I need to work across different areas in my community, right? Do I need to think differently? And I think some of the areas that the calculator asks you to think about, or especially if you use the advanced side of the calculator, and the activities and the worksheets provided by the calculator, you could kind of logically extend some of that to do more with the community-specific services. Though the calculator won't, do that for you, you can do similar activities for that. I do think, though, that there are entirely separate community-specific services that are not within the foundational areas and capabilities, right, that your agencies might do. And that's something where I think working with the 21C learning community or working with consultants or other partners within your community, that's about starting a conversation. And I hope that this calculator can be a tool that's part of that toolkit, but it's not the only thing, right? There are many different things you might need to do to start that conversation, but this is just the first of those things, is my guess.
So I wanted to jump in on this too. I think that's a great question about how this might relate to the community health improvement plan and echo everything that JP just said. I also want to note that obviously with community health improvement plan strategies, implementation strategies, often the attention, the accountability, the work that is done to address those different priorities are not only, of course, and should not be only within coming from within the health department, and there are opportunities for and there should be other assets in the community and partners leveraged to address those. But the part of the foundational services is, of course, the role that the health department can play in partnership engagement and having a community health improvement plan. So there's certainly a connection there. And you didn't this was not asked in the question, but I do want to bring up the strategic plan, because I do think there's a lot of value for using the calculator, for thinking about the staffing that are needed that might also tie into thinking about health department and organizational specific strategic planning, in addition to, of course, the funding and the workforce development planning that you do. So just wanted to bring that plan into, raise that as another relevant link.
Thank you both. And both of those comments are a nice segue into what might be our last question, given the time, which is thinking about next steps. And I'm going to lump together 3 or 4 different questions that were asked and turn it over to everyone to feel free to share any thoughts. which is what would be the next steps the health department would take after getting their results from the calculator. So how do you know what kind or what type of staff you need at what levels and what positions? Often there's overlap in how people work. They don't work on one thing. Many people in health departments wear many hats. How is that, accounted for here? And then specifically, how would an existing workforce development plan, to add another plan to the mix, especially a gap analysis, be incorporated into this overall analysis, if at all? So I'll open the floor to each of you to give any kind of final parting thoughts on any aspect of that very long question. Who wants to start?
I'm going to jump in on the workforce development plan question because I think that's a really good question. Workforce development plans obviously aren't and should not be static things. They are, they should really, of course, lay a path to understanding the workforce in the jurisdiction and the needs, and of course, thinking about both pipeline and succession planning opportunities. But I think the calculator, as that workforce development plan is updated, as you're looking for opportunities for what is our reality, where do we need to be going? I think the data that you get from the workforce calculator or the insights can lend itself to how you may want to update and understand where you take that workforce development plan.
And I'll piggyback onto that by saying that there are also, just like the calculator uses a lot of different types of data to produce these estimates, there are also a lot of different types of data that are available to you all that you should think about when you're thinking about what these estimates tell you. So if the agency participated in the NACCHO profile and you have data that you can link to that, or if you participated in the Public Health Workforce Interest and Needs Survey, those really provide you with opportunities to look at supervisory levels, which I know was a question that came up, Jessica, and you can look at other workforce characteristics and demographics and how that might kind of play into all of these pieces, because we all know that staff it's a lot more nuanced than just the job that you are performing.
Thanks, Mariah. JP?
Yeah, as Mariah and Liza are alluding to, workforce development is this like multi-varied, splendored thing, right? And there is a lot of opportunity for data out there to inform your thinking and decision-making, which is great and can also be fairly overwhelming. I would say that leveraging the resources that exist, whether PH wins, working with your regional public health training centers, working with TRAIN, CDC TRAIN, the Public Health Foundation, and these kinds of resources that are now going to be brought to bear from the CDC workforce NOFO that will be released soon, right? There's a lot of stuff now in the spotlight because workforce is now in the spotlight, which is great. And I think that it's probably no one tool or no one thing, but that the calculator was created to fill a niche that hadn't been filled before. That is supposed to kind of empower individual health departments to think about, where do I sit relative to health departments kind of a comparable size, relative to a national benchmark, and thinking about, what comes next after COVID. But kind of keep in mind that there's a community of peers out there going through the exact same thing as you. You guys already know that. You work with folks all the time. And this is one more tool that lets you make those comparisons. But that those tools can be incredibly valuable, but you need the local context you have to make sure that those numbers make sense, and to always feel like, well, yeah, that looks helpful, and yeah, that might be data informed, but at the end of the day, I feel like I need these occupations within, say, environmental health to be able to do the work that I need to do. I think that trumps it for me every time.
Sarah, any final thoughts from you?
Yeah, if you're a local health department and you're not yet involved with your state association, I would highly recommend that you get involved, become a member. That way you can talk with other local health departments across your state if you're not already doing that. If you're in a state that doesn't have a state association for local health departments, I would reach out to your national association, NACHO, because they are, I think, willing to help states establish state associations. And if you're from a local health or a state health department, I would really strongly encourage you to reach out to your state association and see how you can leverage their capacity, maybe contract with them, fund with them. That will strengthen state and local partnerships. And yeah, that's my plug for associations.
Thank you so much, everybody. And I think it was summed up well that this is one tool in a toolbox, and we hope that it's a very useful tool for health departments in their workforce planning efforts and their advocacy or education efforts when we think about the estimate as well. And hopefully you see also how national and federal organizations are using the data that we know takes you a lot of time to contribute to when you complete the SO and HO profiles, or you complete public health wins, or you complete the cost and capacity assessment. We're putting that to work to create tools for you. So thank you for your time, and thank you all for all that you do. I thank my panelists today and everybody who contributed to the Staffing Up initiative, and you may now disconnect. And as JP said, happy calculating. So have a great afternoon, everybody.